That is in women. I am a urogynecologist, so I specialize entirely in pelvic floor disorders. A significant proportion of what I see is urinary incontinence, and I spend a lot of my time talking to women about urinary incontinence. And I find this to be an important topic, and actually I might have volunteered, Kristen, I'm not sure, to talk on this topic, but it is something I feel really strongly about because I feel that for a variety of reasons that I'll discuss, or at least a couple, I feel that women are not generally very knowledgeable about their bladder, which is fine. But I think that public awareness in this topic is not where it should be. At least I think it has room to improve. And so this talk is really meant for any woman. It's not really necessarily geared towards healthcare professionals. It's really meant for anybody, any woman that has a bladder, I guess you could say, who might run into problems. And it's about how can we look after that and not necessarily prevent, but manage what we're dealing with. Perhaps even before you need to see a physician or before you even need to see someone like me, which might seem a little bizarre that I'm talking about how you don't see me. But I think it's important. And I think that if women had this knowledge or had greater awareness, that the prevalence of these conditions would be a lot less. So the objectives of my talk are simply to help women with urinary incontinence before they need to see a physician through knowledge and through high quality information, and to demystify a topic and raise the awareness, and to open discussion and answer questions. So I welcome the opportunity to answer questions. So I want you to type in the chat box any questions you have about urinary incontinence. I'm not discussing surgery or medical management today. The purpose was to discuss non-medical, non-surgical options. But I'm really actually willing to answer anything. I think it's important to have those opportunities. So if you have any burning questions, please put it in the chat box and I will answer at the end, because I have about 23 slides, so we should have room at the end to answer questions, and that was part of my goal. So what is a urogynecologist? And this is especially for people that have not met anybody like me or who have not sought any care or had any knowledge about urinary incontinence. But a urogynecologist it can be a urologist, or in this specific instance, an obstetrician and gynecologist specialist that dedicates themselves to the medical and surgical management of pelvic floor disorders. So the top two things that I see and deal with are urinary incontinence and pelvic organ prolapse, but there's a long list of other things that I would accept referrals for. So this is literally all I do with my time in my office, what I spend all my time doing every day. And so I have been able to observe over time the general public knowledge level and women's awareness, misconceptions, concerns, anxieties about all these issues. And I really see a lot of patterns. So that's, again, why I'm happy to talk about this. So basically, our bladder is actually quite complex in its function and relatively simple in its anatomy and structure. So that is how we end up with so many problems with it, and that the functioning is quite complicated. When we're toilet trained as toddlers, we learn to recognize the signals that our bladder gives us in terms of when we need to pee, how urgent is it, when to go to the washroom at a socially appropriate time to empty our bladder. And so the point is that our bladder is actually a conscious experience, and what the messages it gives us may not always be accurate, but it doesn't really matter. What we're dealing with when we have pathology and problems with our bladder is the annoying or undesirable messages or events that our bladder creates for us. And it creates those through the nerves in our pelvis, up through the spinal cord into the brain. So if we were under anesthetic, or if we were, spinal cord injury, or things that would change our perception or our sensation, our bladder wouldn't necessarily bother us. But as conscious human beings walking around, having other functions and going about our daily lives, we notice it when things go wrong or when they go awry. So our bladder is like a balloon that is meant to fill and then at an appropriate time contract, send the message to the brain that says, I need to pee, and then contract in a coordinated fashion along with the relaxation here of the pelvic floor to let the urine out. So there's a muscular bladder wall, and then this line of muscle here is meant to be the pelvic floor that helps with a little bit of the squeeze pressure of the urethra, the tube we pee out of. And so you have to contract the bladder muscle to squeeze, to either send the message that I need to pee or to empty. And then at the same time, coordinate the relaxation here to open the pipe to let the urine out. And so every single step along the way needs to be functioning for it to be working perfectly. And that's why things can sometimes occur easily that make it function otherwise. Overactive bladder, which is really only one of the things I'm going to talk about, is a particular kind of condition where there's a abnormality in bladder storage. So now the capacity of the bladder is less. They're going to be sending earlier signals at a much lower volume, and you're going to be experiencing the feeling of needing to pee very strongly, whether or not there's a lot there. So that's just simply to say that it's quite complicated, and there's room for things to go wrong. So urinary incontinence in women and in men, but we're talking about women today, is the involuntary leakage of urine that affects our life somehow. We used to say it was a sanitary issue or a psychological issue or an emotional issue, but really it's all of those things. So if the problem is affecting someone's quality of life, then it's important. Some women, they leak urine and it doesn't affect their life, it doesn't bother them. And really what we do and whether we do anything about it depends on whether it's affecting someone's lifestyle. A huge point of my talk is that urinary incontinence is extremely common. Literally, they're now estimating up to 50% of women will experience incontinence in their lifetime. And these numbers are always fluctuating because frankly, it's a difficult thing to study. Many women suffer in silence and don't actually want to report it to anybody, either in surveys or to their doctors when they do these studies. It's a huge worldwide health concern, and the industry for incontinence products is now up in the billions of dollars in terms of pads and products to deal with the leaking. So there are different types of incontinence, and I say this to every patient of mine when I talk to them about their urinary incontinence to help them understand their options. The three main types of incontinence are similar in percentages and prevalence when you look at the pie graph. Stress incontinence is the loss of urine with laughing, coughing, sneezing, running, jumping, getting up from a chair, screaming, yelling. Jumping up and down on a trampoline is about the worst thing you can do in that regard. Any physical activity that creates a small squirt of urine at the same time is stress incontinence. Urgency urinary incontinence, or urinary urgency incontinence, that should say, also known as overactive bladder, is not with a laugh, not with a sneeze. This is the one that I was discussing on the previous slide, where you may get the sudden urge, like you better run or you're not going to make it. You have to know where all the bathrooms are. You're peeing more frequently. You're getting up more times at night. Very common as well. Mixed incontinence is when you have a little bit of both. So many women will relate to that. They can recall times where they had a laugh or a cough and a leak with the stress incontinence. They had a sudden urge, like they better run, or they leaked on the way to the bathroom. And that means that they may very well have mixed incontinence. A little bit of both. Voiding dysfunction I have there in brackets because it's a more complicated topic that I'm not going to discuss much tonight, but this is what we used to call overflow incontinence. Basically where your bladder gets so full that it just lets go, or the pure hydrostatic pressure causes it to overflow. Or what we're talking about though is an element of incomplete emptying. And the reason why that's important is because it's actually very common that we don't empty our bladders completely. And if we don't empty our bladders chronically over time for whatever reason, whether it's due to habit or due to a medical condition, it can make the treatment of the other ones much more difficult. So one of the things I'm always talking to women about is making sure that they take the time to empty their bladder when they go, because our bladder adapts over time. It adapts to our poor habits. It adapts to our good habits. And so you can actually change some of these functions if you're aware of them. And that's why I feel that this is important. Risk factors means what types of things that occur for a woman make it more likely that they're going to experience incontinence. So there's no doubt when it comes to stress incontinence, as I put the abbreviations there, that if you have any pregnancies or vaginal births, you're going to be more likely to experience it. It's not that a cesarean section is protective completely. Any pregnancy will increase your risk of having incontinence either immediately, during the pregnancy, after, or later in life. But stress incontinence is going to be more associated with the higher number of vaginal births that you have. Your urgency urinary incontinence or overactive bladder is something that can come the longer we live. and is not associated with having had any pregnancies at all. So the point is that it doesn't mean you're not going to have incontinence in your lifestyle if you don't have any children. Just being female, frankly, and living a long life can put you at risk. Some types of incontinence will become more likely after we lose our hormones when it comes to menopause, just that the way the tissues are affected in the vagina and in the bladder. And a huge impact on the likelihood of having incontinence is if we are carrying extra weight. So this is something I'm going to talk a little bit more about. And I do talk to my patients actually about their weight, because like many other medical concerns and with our overall health, it'll increase your likelihood of having incontinence. Some of the other things that make my job difficult are when women have other medical concerns like diabetes or lung disease, smoking, or smokers with chronic cough. These conditions are probably the most common things I see that make the incontinence worse, harder to deal with, or more resistant to treatment. Diabetes affects the nerves in our body. So if you think again about that picture I showed with the bladder and how it can be complex with its nerve messages to the brain, if those nerves are not functioning for whatever reason, whether it's a neurologic disease like Parkinson's disease or multiple sclerosis, diabetes is more common than those things, and diabetes can affect your nerves and over time affect your bladder as well, and people don't know that, I find, very often. Lots of medications that people take maybe for high blood pressure can also affect their bladder function. So that can sometimes even result, frankly, in tipping somebody over the edge and actually having trouble with incontinence if they're on medications that make it worse as well. So how do you know? If you're a woman and you've not seen a practitioner, if you've not mentioned it to your family doctor, if you're listening to this talk, how do you know what kind of leaking you have? Let's say you're experiencing it and you listen to a talk like this and you want to know what's going on with yourself. Well, when you go to a doctor, we evaluate the incontinence first by talking to you about it. And I have on the next slide some questions that can help to trigger and decide which category of incontinence you might have. We do urine tests to rule out infection, because it is important to know that a urinary tract infection can also be a cause of incontinence that is treatable. We do a physical exam to make sure that there isn't anything physical, or maybe there is, that's making the incontinence more likely. As I mentioned, bladder emptying is important. So sometimes we'll do simply an ultrasound, or we can also check this on physical exam, how much urine is left over after you pee. That's again called the post-void residual, because not emptying can create more problems and make everything more complicated. I perform urodynamics, which is a specialized bladder function test, which is absolutely not necessary to initiate conservative management for your incontinence and many other medical managements that we may talk about or that I may prescribe or offer in my clinic. Urodynamics is for select patients that are more complicated or for planning surgery or more complex things, and it is not necessary for most women. So ask yourself, when do you leak? Do you leak with a laugh or a cough or sneeze? As I said, it's very obvious. It's going to be stress incontinence. But sometimes it's still stress incontinence and it's not one of those activities. Let's say you're not the type of person that's going to go jump on a trampoline. Some women, simply from getting up with it from a chair, will have a leak of urine come out, but they didn't feel like they needed to go. So that as well can be stress incontinence. Lots of women, stress incontinence will affect their ability to exercise, and they will actually avoid exercise because of it. And I meet a lot of women who are runners. And if you're leaking during running, you have stress incontinence. You might have urge incontinence, but if it's just with the running, without the feeling of needing to go, that again is the stress incontinence. Let's say you feel a strong urge and you can't get to the toilet fast enough. It's more likely then that you have urgency incontinence. What I love to talk to women about that usually makes them laugh is when I talk about turnkey incontinence. If you get to the house after a long day out, especially in the winter because cold makes it worse, you get to your door and you have like this sudden feeling like you better run or you're not going to make it. That is the connection between your brain and your bladder that is very strong that you're observing. And I'm not saying it's abnormal, but if you leak on the way to the bathroom in that instance, that is urgency urinary incontinence or overactive bladder, which is your bladder contracting and forcing the urine out before you get there, associated with a strong feeling or message that you need to go because of that contraction. And if you're the kind of person that has to know where all the bathrooms are when you're out, when you go out to the mall, or when you go to a friend's place or anything like that, or when you go out for a walk in your neighborhood, and there's stores nearby or places where there's safe to use a bathroom, it's safe to use a bathroom there, it's more likely that you have urinary urgency incontinence or overactive bladder. Again, just because of the frequency that that condition will create for somebody. So what do we do when we experience symptoms? Well, let's really be honest about this. We go on Google. And there's nothing wrong with seeking information. I believe really strongly in that. The problem is that the internet, it doesn't have a quality control on it. And we are definitely in need of more high quality online resources that help women to know what to do in these instances, to understand what's normal and what's not normal. Because pretty much you'll find anything on the internet. You'll find anything you want to find, and you'll find anything that you don't want to find. So I like to usually put up some of the statements that I often hear over and over and over again from people, either women, either because they found them online, or the next thing that we do when we're trying to research a condition or a symptom that we have is we talk to other people. If we're comfortable with talking to other people, sometimes we aren't. But we tend to gain great perspective, and I have generally observed when I talk to women about incontinence, they bring with them the collection of information that they've received online or from others that definitely impacts their perception of what they have and what they need to do about it. And so one of the things I would like to do is to help get high quality information out there so we can dispel some of the myths and have the right information that women deserve. So some of my favorite statements are, I've already done my Kegels, they don't work. Or my neighbor says pessaries can cause infections and bleeding and are awful, so I'll never use them. Or I've always been this weight and I never used to leak, so losing weight won't help me. Or my sister family doctor says surgeries don't work anyway, so I definitely don't want a surgery at any cost. And again, misconceptions and perceptions and information that they bring with them. And so we should. We don't live in isolation, and these are the places we go when we seek information. So we get all this information, we talk to our other women in our life, and they say, oh yeah, I leak when I laugh or cough or sneeze as well. That's normal. Lots of women say to me, isn't it normal? And I say, no, basically. But I say that with compassion, because I think that as busy women and human beings these days, I think we discount our symptoms sometimes. I think we get used to looking after everybody else. We get used to our busy life. And when everybody else experiences it as well, we tend to minimize it. My answer to that is that I have a problem with the word normal. I would prefer to say that it is common. So that's the way I talk about it. And because normal implies that it's acceptable, even if it's affecting your life, and you just carry on with your life and you ignore it. And that should not be the case. And I genuinely feel that. The picture on the right is a magazine image from quite a number of years ago that I've used in a lot of talks. And I always like to put it up because I like to say that we need to beware of messages in the media. And social media, I think, is doing a better job these days with having high quality information, and more physicians and knowledgeable health practitioners and experts are giving high quality information. But in the past, celebrities would participate in ad campaigns. And for me, I'm happy that it is out in plain view that a celebrity might be wearing a pad or discussing an incontinence product. But at the same time, to me, the message is put on a pad and keep going. Just ignore your problem, when in fact there are solutions and things that can help. So that's why I have a love-hate relationship with those kind of messages. So what I want to say to all women, and I say to women a lot, give yourself permission. Give yourself permission to acknowledge the fact that this is a problem, that it is not normal, and you do not have to live with it. Give yourself permission to report this to your doctor, to your family doctor, to your pelvic physiotherapist, to your friends. And if you're finding yourself bringing it up and the women in your life are uncomfortable with the topic, well, there's another reason why we should be talking about it more. We should all feel more comfortable talking about it. And many of us are embarrassed, but let's make it a topic that we can all talk about so that we can help each other. Give yourself permission to make changes in your lifestyle, which I'm going to talk about a little bit, that can help you even before you see a doctor, and to ultimately get help if you need something more done. So, conservative management of urinary incontinence. What is conservative management? So as I mentioned, in terms of my subspecialty, it's the medical and surgical management of pelvic floor disorders. But why am I, someone like myself, discussing this? Because I think it's important that women have a general knowledge about their body, but also what they can do before they even need to see a physician. And I know it seems odd that I'm trying to spread the message, that women don't need to see someone like me, but I have noticed time and time again a lack of awareness, like I've mentioned a few times now, in this area. And I feel that this needs to be improved, and we can do this together. So I'm going to be highlighting some basic knowledge on how our body works, as well in terms of my suggestions for good bladder habits, which is what I call it. And that many of these conservative management options, or any therapy that does not involve a medication or surgery, can be employed before you even see a physician. And in my opinion, if we adopted this knowledge and these practices large scale, it would help many women and reduce healthcare burden. And we would live healthier, more satisfied, less affected lives by these conditions that affect our quality of life. So this is a publication that was published in April of this year, during the pandemic, of course, but has been actually in the works for a number of years because it takes a while to develop a document like this. But the SOGC is the Society of Obstetricians and Gynecologists of Canada, and there are a number of medical societies that publish these clinical practice guidelines or similar kinds of documents that guide physicians and healthcare providers with the best practice on certain topics. So we have one that was now published on conservative care of urinary incontinence. Some of the studies in this publication were studies that I did, and I know the authors really well, and so it's an excellent document. But this is a medical document. But what's important to know is that the information doesn't have to be just for medical practitioners. It's information that we should all have. So the first thing to consider is lifestyle changes. And I'm talking about this in terms of the fact that these changes can help all kinds of urinary incontinence: urgency incontinence, stress urinary incontinence, and mixed incontinence, meaning a little bit of both. So there's hard data now that is showing that weight loss or reaching a healthy weight improves incontinence, most definitely. If you want numbers, there was a study that they looked at women who were undergoing bariatric or gastric bypass surgery to lose weight, and 5 kilograms of weight loss improved incontinence of all kinds by up to 20%. And that's significant, okay, if you look at medical interventions and studies without having to go into numbers too much. But the point is that, we think of weight as having such an impact on our health in a number of ways, whether it's our heart, our blood pressure, diabetes, and the associations, but people don't often talk about the fact that it can affect your bladder as well. But the point is, our bladder is part of our body as well, and our overall health helps bladder function when we improve that as well. So we're talking about a healthy diet, in my opinion, as many fruits and vegetables as you can get into your body, and conversely, therefore, avoiding constipation, with bowel function being very close by, and also can affect our bladder function, and adequate water intake. These are all things that you would do perhaps for other reasons to help your other body symptoms. Your pelvic floor, again, that diaphragm of muscle in my picture with the bladder that is providing some support to the continence mechanisms, is a muscle like everywhere else in our body that should not be ignored. And therefore, greater awareness needs to be there. Basic exercise, even just walking, although it's not deemed a quote pelvic floor muscle training activity per se, the point is basic fitness, even if you're just doing walking, it will help activate your pelvic floor and your core a little bit than it would if you weren't doing it at all. And so these things help maintain our bladder function indirectly as well. But the point here is that the science definitely supports weight loss. And so I talk to women about that as much as I can. Behavioral modification is another category of conservative habit changes and sort of adjustments, I guess is the word I'm looking for, in terms of what we're putting into our body. So caffeine is a double-edged sword for our bladder. It is particularly going to exacerbate urgency incontinence or overactive bladder, because caffeine, although we love our coffee, is a diuretic. It will fill up your bladder faster, but it will also irritate the bladder and make you feel the sensation that you need to pee perhaps earlier than you needed to, like that picture I showed before with the bladder, which wants to contract at a smaller volume. It'll give you an experience or a sensation that you need to pee when you otherwise wouldn't if you drank a different kind of beverage. The studies on caffeine were actually in men, but there is one small study in women that showed a similar effect. And so this is something we talk about a lot. Alcohol has a similar impact on the bladder as caffeine, being a diuretic and an irritant. So it's going to increase your experience of needing to avoid or being annoyed by having to go to the washroom, and also increase the volume entering your bladder from your kidneys. I talked to women as well about managing the timing of their fluids. I'll talk a bit about that on the next couple of slides, I believe. But also the fact that our bladder should not be completely ignored. A lot of women I talk to are very proud when they don't need to pee for 6, 7, 8 hours. And unfortunately, that's not a good thing, and not something to be proud of. Our bladder is meant to fill and then to empty completely, and then to fill and then to empty completely. And the longer we go, the more overstretched our bladder gets. It will adapt for us, even in an abnormal way over time. But the problem with that is that eventually it will either lose its ability to contract and empty like an overstretched elastic band, causing us to not empty completely. And like I mentioned before, that makes everything more complicated. So I tell women to go regularly, go every 2 to 3 hours, even if you don't think you need to go. These are habits that we need to train our bladder to continue to do and not get carried away with our busy lifestyle sometimes and ignoring it completely, because it may cause us long-term problems. Bladder drills or bladder training is sort of a category of interventions that fit into the category of behavior modification, again, trying to adjust our habits. And the idea is, at a time when you're home or when you're not, doing something important or at work, if you can, learning to slowly increase the interval that you might feel an urge to pee for women who have frequency or urgency or urge incontinence, by knowing that you're in a safe place and distracting yourself to delay voiding by intervals. This is for the category of women that actually have a problem where they pee very frequently, not the ones I previously mentioned that can go hours and hours. So the point is, we need to kind of fit in the middle ground and go and kind of fit between these extremes. And sometimes we can use sort of mind over matter or slow adjustments to help our habits, and that will translate into changes for our bladder and our quality of life as well. So this is my list of healthy bladder habits to sort of summarize that. This is not, all hard and fast science backup, but this is what I say to women that is my advice, basically, from the knowledge that we have. Water is the best thing to drink, but don't force it. So I'm definitely not saying don't drink water. And once I gave a talk and someone came along and said, "Oh, Dr. Best said don't drink water," so I stopped. I only drank 2 glasses a day. I'm not saying dehydrate yourself, but I talk to a lot of women who impulsively or compulsively rather sit with their water all day and actually do not know how much volume they're taking in. And if you have a bladder problem and you're drinking more than 2-3 liters of water a day, you might be causing yourself more problems than you need to. So, there is actually no science to back up the notion of drinking 8 glasses of water a day. Water is the best thing to drink. Go ahead and drink it. Drink it. It's the best thing to drink. Avoid caffeine, avoid alcohol if you can. Not with 100%, avoidance, but just knowing that you might have more issues when you consume those fluids, and don't be surprised. But know that the 8 glasses of water a day thing, nobody knows where that came from. If you're a smaller person, you may not need 8 glasses. 6 glasses is fine too. But sometimes we need to stop and actually record or pay attention to how much water we're drinking to know that we're not making matters worse for ourselves. Drink mainly between breakfast and supper. So I see a lot of women that have trouble with getting up at night to pee. And unfortunately, our kidneys will create urine overnight, whether we drink fluid or not. And so therefore, it is normal to get up to pee once during the night. If you have some overactive bladder symptoms associated with urgency incontinence and you're up 2, 3, 4, 5, 6 times at night, your sleep will get affected. And so it is best to try and avoid drinking fluids after supper. I'm not saying drink less. Again, drink your 6 glasses of water or even 8 glasses of water if you want, but drink it between breakfast and supper and then stop. If you avoid fluids in the evening, short of doing more interventions, that will reduce the fluid, the urine production overnight. Some of us work all day, And on the flip side of the people that sit and drink water at their desk all day, we run around, drink nothing, get home, and then do all our drinking in about a 2-hour span. That is going to be a problem with sleeping for many people, especially if you have a bit of overactive bladder or urgency incontinence, because you're going to be up more. And our bladder, again, will be affecting our quality of life, and we may even be getting up urgently to run to the bathroom and actually leaking during the night. So that can definitely affect our life for sure. Pee or void regularly, like I mentioned before, every 2 to 3 hours. Do not wait until you're desperate. Everybody's bladder has a limit by which it'll say no thank you, and all bets are off. Many women who have incontinence have it in a way that I describe as volume related. So many women may not complain or notice stress incontinence, again, for example, leaking with a laugh or a cough or sneeze. But if they drank a bunch of water and had, let's say, a liter of water, and that's a lot. Most of us will have a capacity of 500, but many of us can train our bladder to hold a liter for sure. Let's say we had a liter in our bladder and we coughed. Well, your likelihood of leaking is significant. But if you didn't allow yourself to get that full and allowed your bladder to function at more normal volumes, you may not leak at all. So that is how incontinence can be volume related. If you go regularly, every 2 to 3 hours, that's considered a normal frequency. And again, this is for the people that delay voiding. Do not wait until you're desperate, and you may be able to avoid some of the problems. Also, for people with urgency incontinence, sometimes they complain of, oh, I better run or I'm not going to make it, but they don't realize or they forget that they haven't peed all day. And if they go more regularly, they can avoid those concerns with leaking on the way to the bathroom. When you sit down to pee, and this goes with many other things in our busy modern life, don't be in a hurry. And I meet a lot of women that are afraid or don't like public washrooms, and I get it. But at the same time, a good bladder habit in terms of voiding is to sit down, take a few deep breaths in and out, whether you do yoga or not. Take the time to let everything out. And even when you think you're finished, lean forward, stand up, sit down again, and give a few more pushes. You're not going to harm yourself. It is important to do your best to empty as much as you can. In doing so, you'll notice sometimes you get a little bit more out. And that's a good thing. You are now training your bladder to empty the best you can every time you go, rather than walking around with a little bit left over all the time, because you didn't make that a practice. And then, like I said, running into problems, or if you have incontinence, making it much more difficult for us to treat or to deal with. So one of the biggest conservative interventions for all kinds of urinary incontinence is pelvic floor muscle training. And that's what we call it. This is where my favorite friends, the pelvic physiotherapists, come into play. I am able to assess pelvic floor strength. Many medical practitioners are not, but it is increasing in knowledge beyond just physiotherapists. But it's not my area of expertise to really work with women and teach them the correct activities on how to increase their muscle strength, endurance, power, also ability to relax completely, and therefore coordination. So you can understand more now about what I was saying about our pelvic floor being a muscle that cannot be ignored and is just as important, if not more important, than all the other muscles in our body, but we love to ignore it. Well, we shouldn't be. It's not just about doing your Kegels. It's about all these functions to allow for the muscle to work for us with the correct function in a coordinated way. And it's that kind of work that requires a professional. And in my opinion, you haven't really done your Kegels, quote unquote, if you haven't seen somebody and ensured that you're doing it appropriately. We have studies that show if you give a handout to a woman and say, go do your Kegels or just do some squeezes, that's not effective. Okay, so it requires many times to at least being examined or to know, have an assessment of your pelvic floor to have adequate instruction on what you're doing. Pelvic floor muscle training is the first line therapy for all kinds of incontinence. The mechanism by which it helps the stress incontinence, laughing, coughing, sneezing, is much clearer, but it definitely has been shown to help with urgency incontinence and then therefore mixed urinary incontinence as well. And it's always going to be more effective if you have an individualized treatment sort of assessment and plan with a professional. Pelvic floor muscle training helps as well with other things like sexual function and pelvic pain. So it's not just for urinary incontinence, and the list is expanding, and it's really exploded in the last 5 to 10 years for sure. And I'm sure Kristen would agree. Why do we why don't we do postpartum pelvic floor rehabilitation? And this is becoming more and more common, and the awareness is improving here. But knowing that having a vaginal birth and being pregnant can be such an event, if you will, for our pelvic floor that can affect our bladder function in the short and long term. In other countries, in fact, in France and in Europe and other places, it is part of the healthcare coverage plan to have pelvic floor muscle training or assessment by physiotherapy postpartum or after giving birth. I think that's incredibly important. And I think that we should be doing that, because to me, this is something that may even be preventable. Adjunctive treatments for pelvic floor muscle training are basically any kind of treatment, technology, device that can enhance the actual intervention. So what we're talking about here is still pelvic floor muscle training in terms of the pelvic floor, but there are different products, some of which some of you might have heard of. Vaginal cones are little weights that are placed in the vagina of increasing weight. And the idea is, like other weights that we would use for exercise, to improve the strength by being able to hold weights of increasing amount in the vagina to strengthen the muscles. The problem with that is that it does not allow for the also the converse relaxation that's required to improve the whole range of motion with our pelvic floor, as we would with any other muscle. But it is something that people will help some women who already have that awareness have the right cues, and in fact give them something to work with at home. So some people like it. I don't find that it's used a lot, but that it definitely is something that an adjunctive treatment or device. Other kinds of technologies might include biofeedback or any kind of device, whether it's in the vagina or a chair that you sit on, for example, that provides some kind of electrical muscle stimulation, almost to mimic what the pelvic floor, muscle training would include, although you're not necessarily initiating it yourself. And the point of these devices is that they can be helpful, I think, and if Kristen wants to talk more about this later, she might, for women, simply because they may improve compliance or assist in a program or a technique that they've already been taught. But these technologies and adjunctive treatments, the point is, have not been shown to replace pelvic floor muscle training with an experienced, knowledgeable practitioner. They can enhance it or provide women something to work with at home. And new technologies are always being created, but they are not superior in terms of results. The next thing to talk about is something that I often show to women in my office, and there, again, are always new things being created. Now we're talking about intravaginal devices. So another name for this would be a pessary. One of the things I deal with a lot is pelvic organ prolapse, and we probably use pessaries more often for prolapse than we do for urinary incontinence itself. But there have been some devices and pessaries that have been designed specifically for leaking or incontinence. So the Impreza is a disposable tampon-like device that is made by Poise pads. And the idea is that when something goes in the vagina, whether it expands or is placed in there and is expanding the vagina itself, it's creating upward pressure against the urethra, which is right in front, which is where we pee out of. And this is for stress urinary incontinence, to stop the sneeze leaks, if you want to call them that. So the idea is they're providing a little bit of partial obstruction or support, really, to a weakness that is the cause of the stress incontinence, to help reduce the likelihood of the leaking. The Uresta, which is the picture I have there, is a pessary for incontinence. It's a device that goes in the vagina that I did a study on during some part of my training. That has been shown to help with stress incontinence. It comes in a variety of sizes, and this was created by a urogynecologist for the purpose of allowing women to have an option while they waited to see a specialist or even to see a doctor. Something you can buy online, and to this day, you can go on the website, you can buy it online, you can buy it in a kit of 3 sizes that allows you to experiment with the different sizes to see what size you need to create the support that you need. So Dr. Scott Farrell created this. So 66% is the number from their website that I've also seen as well. That is the number in terms of the women that reported significant improvement. And again, 72 would recommend it to a friend. Although it looks a little intimidating, when I show it in real life, look at me and say, that looks huge. I'm like, well, there's different sizes, so that's important to know. But 80% reported that it was very easy to use. So during my training, I did a study on the straight objective amount of leaking that was reduced, or the true, decrease in volume of loss from using a Uresta compared to a sham device, or a placebo, if you want to say. And it did significantly reduce the leaking experienced by women with pure, simple stress incontinence. The only limitations that we had, again, were women with extremes in anatomy that simply couldn't get a size that was comfortable. So I would say that the limiting factor is whether you can handle it and it's comfortable. Again, 80% of women said it would be, and the majority did find it easy to use. But it is a device that is designed specifically for stress incontinence. And so frankly, in my opinion, what do you really have to lose? It's definitely something to consider. And again, we always try conservative options before we get into more invasive options, because stress incontinence is the kind of incontinence that someone like myself will do a surgery on. So I am a huge supporter of these kinds of devices. There is also something called an incontinence dish pessary, which I have in my office and other doctors might have. This requires more of a fitting, and incontinence dish pessaries are more likely to help in a combination of prolapse and incontinence. But the point is that some pessaries for prolapse have provided additional support to help with stress incontinence at the same time. So those are the intravaginal devices. When they've looked in the studies and in our SOGC guidelines that I showed the title page of, in terms of again, how effective these are, they've compared intravaginal devices to pelvic floor muscle training. And pelvic floor muscle training done appropriately with an experienced practitioner does come out on top as being more effective, even more effective than using them in combination. The women that I see that have been very happy with the Uresta are the ones that are going to go do a sport or go to the gym, a physical activity that will otherwise make them leak that is predictable, and they will use it during that time because it can be in the vagina 8 to 12 hours. I think the product monograph is 8 hours, but you can leave it there 12 hours as long as you take it out to pee or can actually void. And they've been very satisfied with it under those circumstances, because it's something that they can do that is empowering for them to do something for themselves to decrease the leaking that otherwise may actually prevent them from participating in those activities. So that's the information that I had basically when it came to conservative management. In summary, and my final points, urinary incontinence is common. It is not normal. So don't call it normal, and tell all your friends not to say that it's normal. Just because a lot of us experience it doesn't mean that it's okay and it should be ignored. Simple behavioral changes and good bladder habits can improve your bladder experience and the experience that you have with the bladder that you have. And I joke around with women and I say, I can't give you a new bladder. We haven't created bladder transplants. So we have to work, and I'm kidding, of course, but I'm serious, and that we have to work with what we have. And even if we do a surgery, even if we do something more invasive, it doesn't mean that all our habits get thrown out the window. And that is also why these points and these conservative options are so important, because you still have to function with your bladder forever, even if I do a surgery on you. And it's important that you do the best you can with what you have. Practices that are generally healthy for your body, including healthy diet, weight loss, and the such, will help your bladder as well, whether it's low impact exercise, avoiding constipation and things such as this. Conservative options that are most supported by science and evidence are weight loss, for sure, and pelvic floor muscle training, again, most effectively guided by a trained healthcare professional. Intravaginal devices can also be helpful without having to see a healthcare professional. They are available online. In fact, I am not even allowed to carry the Uresta in my office. It is for women to purchase on their own online. Please beware of unreliable internet resources and other people's opinions. And I say this just because it's hard to compare ourselves to others. And although we find it helpful, and we should be talking about these issues with other women in our life and other women that we know, whether, these days we're talking mostly on FaceTime and Zoom, as per the cute little Zoom picture I put up on this screen. We're not actually talking as much in person, right, during this pandemic. But try not to compare yourself to others. You don't know what other conditions somebody else has. And even if something worked for them or did not work for them, know that your options are still yours. and try to be open-minded about what's available to you. Effective medical interventions are available if the conservative options aren't enough, but we should all be trying the conservative options first. And I spend a lot of time talking to women about these before we do anything more invasive. So finally, I want to say, spread the word. Let's reduce the stigma, help women talk about these things more, and help have basic knowledge and information on how our body works and how our habits can contribute and how conservative options are available to us if we can. Let's spread the word on those things. So that's really what I have to say. I put there on this slide some resources that are high quality. yourpelvicfloor.org is from the International Urogynecological Association. The slash leaflets is the section, if you go to that website, if you click on leaflets, of all the handouts that you can find on a variety of topics, including what I talked about tonight. Uresta.com is where you can get a Uresta or get more information. I actually really liked some of the patient videos and testimonials they have on that website. I think that's really helpful as well if anybody's interested. Thebellmethod.com is my friend Nikki. She doesn't know that I put that on there tonight, and of course I get no endorsement from her. I mean, I want to endorse though her knowledge, and that she's a Pilates instructor and a part of the fitness industry who cares a lot about women postpartum recovery and pelvic health, and she has some high quality sort of scientifically and evidence-based resources and programs for women to rehabilitate their pelvic floor, which I think is really part of what we're missing in healthcare as well. And that's my website as well, which is definitely not up and running, so don't go to it just yet. But I will be very shortly, within the next week, be putting on some more resources and hopefully some videos as well on how I can help everybody with their knowledge on basic bladder function and conservative options to help them with their bladders. And that's it. Okay, Kristen, I'm going to go to the chat here.
Okay, sounds
and I'm going to look at some of the questions here. So one thing I want to say is that hard for me to answer specific questions about anyone's health, I would say, as my disclaimer over this. I'm going to talk more about general topics and concepts, if that's okay, to answer people's questions. So one person on here is mentioning that since they had their daughter, they were constantly waking up in the middle of the night to pee and have to empty their bladder before bed at least 3 times. So really, it sounds, I would say to this person, you know who you are, I'm not going to say the name, it's a private message, that it sounds like there may be more than one thing going on here. What I would say again is go back to the basic bladder habits that I mentioned before that will help everybody. Pee regularly. Don't wait too long. Take the time to empty every time you go, even during the daytime, even if you have to find yourself going more to pee during the evening. And sometimes getting up at night to pee is, like I mentioned, drinking fluids in the evening. It can also be overactive bladder or urgency incontinence, but it may also be that you're not emptying your bladder effectively during the daytime. And so you're going to bed with a bit of urine in your bladder, even if you don't mean to. But the point is, in terms of all of this, I would say, looking at all the things you've mentioned here, that definitely, you know, your question at the end was, do pelvic floor exercises help with this? And my answer would be absolutely. So I don't know about you, Kristen, but I would say, I think someone like this should see an experienced practitioner in terms of getting some help and guidance and assessment on their pelvic floor, because it's hard to know just with the collection of symptoms what's physically going on.
I agree. I think that sounds like a great plan. And I think, if nothing else, one of the things I often say to women when they come to see me is, with that internal component, they will learn how to do kind of their best pelvic floor muscle contraction. And women are smart, so you give a little bit of information to women and they take that and can run with it. And so even just coming for the assessment teaches women a lot about their own bodies, I think.
Yeah, and also it's like a light bulb goes off. Like sometimes it's just a matter of being shown quickly oh yeah, I get it. Like I'm just saying sometimes it doesn't take a lot. I mean, and I don't know about you, Kristen, but I would say that it depends. Pelvic physiotherapists have different ways of practicing, but I find that for some of you, it's about it's an education as well, and it is a tool that you go with that you can use for really ongoing. And when and actually, of course, as someone who does surgery, I think it's important for women to have this knowledge and this awareness and this physical education of their body, even if we do a surgery, because things can come back. And so I think, having that in your toolkit, even after, is what's going to help you to deal with the bladder you've been given for the rest of your days, even after we do something. So somebody wrote, what is a pessary? So again, a pessary is a rubber device, usually silicone or medical grade rubber. The uresta is silicone, I believe, that is molded and shaped in a way that is meant to fit into the vagina, either to create support to the pelvic organs, which is what is happening when someone has prolapse because they've lost support, or as I showed with the uresta, to help create support specifically to help with certain kinds of incontinence. And in this instance, it's stress incontinence. So question here about pelvic floor muscle training. After the initial assessment, how long to start and see experience results with some improvement, and how long for longer term or more significant improvements? So Kristen, you can answer what you think, but what I was going to say is that I think there is still needing to be some more long-term data. And the difficulty, I think, with long-term is that, humans, unfortunately, sometimes we want a quick fix, but otherwise we also get busy. And it's like other kinds of exercise, right? I mean, I always talk about the pelvic floor being like a muscle everywhere else. We love to ignore it. We can't ignore it. So you may learn like what you need to do, but it actually depends on your ability to continue with that, which I think is going to impact your long-term results. I don't know what you say, Kristen, to people, but I remember a study a while ago where they looked at women doing pelvic floor muscle training, or basically Kegels as they were back then, in terms of what they needed to strengthen their pelvic floor. They would do something like 20 reps 3 times a day. And at 6 weeks, I remember 60% were either completely satisfied that they didn't need anything further, or essentially cured or significantly improved.
Mm-hmm. I think that's exactly it. I think, when we look at the pelvic floor muscle as any other muscle, that lots of times we see the impacts of strength training within 4 to 6 weeks, not to say that there might be some additional effects afterwards. The only caveat I would have there is exactly what we talked about, is some women really have no idea where that muscle is. And so after that assessment, and you said, no, this is the way you need to do it, because some women, upon trying to contract their pelvic floor, do a complete reverse move where they're almost pushing out. And as soon as you get them to do it the right way, then they'll notice, like in the first couple of weeks, they're like, oh my God, this has revolutionized my life. So there are those particular instances, but from a pure muscle standpoint, yes, 4 to 6 weeks, then we usually see those strength gains.
And you're absolutely right. And I didn't mention that, but it is actually unbelievable. They've done studies on this as well, in terms of what women think is a Kegel, let's just call it that, or the correct contraction. It is, some of them are doing Valsalva, like they're pushing out,
Yes.
Or they're squeezing their buttocks together, or they're just sucking their abs in. And that is nobody's fault. You're not expected. We don't know these things. This isn't common knowledge. This is why it's a profession, and why people need help in figuring out what they're doing. Some women talk about voiding just in case before they go out, or before they leave for work. Can you speak to the effect on the bladder when we go often without actually feeling the urge to go? Yeah, I think there's nothing. There's no science behind this. I'm just speaking from in terms of what I think about this. I think there's nothing wrong with going in that instance before you go out. I really don't. I tend to be more the proponent of going regularly, whether you feel the need to go or not, mostly because I think I meet a lot of women that do the opposite, that they go hours and hours and hours without peeing. And I actually think that is more damaging long term than the converse, than going more than you need to when you don't really need to go. I actually think there's some benefit in going regularly, whether you think you need to go or not, and taking the time to empty properly. I think that's more likely to save your bladder in terms of emptying well, and saving you from troubles when you are out and about, or unexpected things happen and you get trapped somewhere and you may need to go to the washroom. I think it's also psychological thing. I think some people feel less anxiety when they pee before they go out, and I think there's nothing wrong with that if they have problems. But I don't actually think it's inherently harmful to pee when you don't actually need to go. I would actually suggest that. Now, that's different from going every hour on purpose. What I'm saying is don't let yourself go hours and hours. And if you are going to go out, sure, pee before you go out. I mean, we say that to our kids, but I think that's a perfectly reasonable habit. I don't know if that answers the question. I think that's it. I think those are all the questions. Is there anything? I don't see anything else there. Chris, I don't know if you have anything in your chat box, but I think that's it.
That's all I have as well. So thank you so much. That was really informative and covered lots of good things that we could integrate right away into our life. So I want to thank you so much for taking the time on July the 2nd. Yeah, and have a wonderful night. And maybe we could do it again in the fall.
No problem. I'm happy to always do this if people have questions. I think I'm always happy to talk about these things. Thank you for having me.
Thank you. And thank you, everyone. Stay tuned. If anybody's interested, through the month of July, we're doing a pediatric virtual health series. So follow us on Instagram or check us out on our web page for more information. All right. I suppose I can stop recording now, can I?
Yes.